Yeah. Okay.
Is it okay with you now? Should we start?
Yeah, we can start.
Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 19M, which is Hematology, Hemostasis and Thrombosis. We are streaming live from Aster MIMS Calicut via Kolkata. And we have a very interesting topic, the Antiphospholipid Syndrome, or the APS. And to talk on that, we have Dr. Karthika K V. She's a very famous hematopathologist, an excellent speaker, a very knowledgeable person. She's an MBBS and MDPath, DNB, and a DM Hematopath from AIIMS, New Delhi. Presently, she is a senior specialist in hematopathology at Aster MIMS Calicut with multiple national and international publications. Uh, Before I ask Dr. Karthika to start, let me request all of you to keep your mic muted, your camera off, and please don't share your screen. Without much delay, I'll just request her, please share your screen, ma'am. Let's start.
Thank you, sir, for that kind introduction. I'm honored for having this opportunity to talk on a favorite topic of mine. Coagulation has always been of interest to me, and even in coagulation, antiphospholipid syndrome has always held my interest because every aspect of the disease needs a deeper understanding, deeper learning, and that has been lacking for quite some time. That is mainly because of lack of literature and lack of awareness of the topic. So I hope I try to make it a little more clear to you, though there are some things I still am not clear myself. So let's go to the topic proper. Antiphospholipid syndrome, as sir said, shortly known as APS. Okay, so antiphospholipid syndrome is basically an autoimmune condition, and this autoimmune condition leads to thrombophilia. Now, what is thrombophilia? Thrombophilia is an increased propensity to develop thrombosis. Okay, so what kind of autoimmunity is present in APS? Autoantibodies are created against plasma proteins that bind to phospholipids. For every autoimmune disease, there is a particular antigenic target, and in APS or the antiphospholipid syndrome, the target of the antibody is the plasma proteins that bind to phospholipids. Here again, there is a misconception that the antibodies are directed against phospholipids. No, it is actually directed against the plasma proteins which bind to the phospholipids. Now, the next question you might have is, why is it the autoantibodies attack them only when they bind to phospholipids? That is because these plasma proteins have a change in their configuration when they bind to phospholipids, and this change in configuration creates a new epitope on their surface, and it is against this epitope antibodies are created. Okay, so that is how you define APS. And how do you diagnose it? It is diagnosed by a combination of both clinical and lab criteria, which we will discuss as the topic progresses. Okay, so why combination? So there is a definite definition for this disease. Okay, autoantibodies against the plasma proteins bound to phospholipids. So why do you need a combination of clinical and laboratory features? That is because both are non-specific on their own. Okay, so you can have autoantibodies that are not pathogenic. You can have antibodies directed against these proteins, yet they do not create any problem for this patient. And you can have the other ways also. You can have clinical manifestations like pregnancy morbidity, vascular thrombosis, yet these antibodies are not there. So both on their own are very non-specific and can happen even in patients without APS. That is why you require both clinical and lab criteria. So what are the clinical and lab criteria? Clinical, you need arterial or venous thrombosis or pregnancy morbidity, and lab criteria, you need persistently positive test for these antiphospholipid antibodies. Now, the entire presentation is going to be focused on these 2 points, the clinical and laboratory criteria. So before we go to that, short description of the history. The initial description was in the 1980s. This is also known as the Hughes syndrome. Now, how they first discovered this was they found out that patients with systemic lupus erythematosus had a high incidence of recurrent thrombosis, and these patients somehow had a false positivity in the VDRL test. Now, VDRL test, we all know, is a non-specific test for the diagnosis of syphilis. It is an ELISA based test where you have reagent. Reagent is a particle which is embedded on the ELISA plate used for VDRL testing. So, these autoantibodies present in APS have reactivity against this reagent as well. So these patients started showing positivity for the VDRL test, though they were actually negative for syphilis. That is how they came to know of this disease. And then, as they started identifying more of these cases and as they started learning more about this disease, they found out that there was a lot of non-specific positivity, and they actually needed to devise a criteria for the diagnosis of this. And an international congress was held, and a Sapporo classification criteria was created in the year 1999. Now, Sapporo is a city in Japan where this conference was held for the first time. And following this criteria, revisions were further made to this criteria, and the final criteria which we use today, known as the modified Sapporo criteria or the Sydney modification of the Sapporo criteria, is what we use now, and this was proposed in the year 2006 at Sydney. So this is the modified Sapporo criteria which was proposed at Sydney in 2006. There is a clinical criteria and a laboratory criteria. Now this slide, I hope, is the take-home message from this class. So you need to be thorough with this criteria. So what are the clinical criteria? The patient should either have a vascular thrombosis or a pregnancy morbidity. Okay, or both. Okay, so if you're diagnosing a patient as APS, he or she should have either vascular thrombosis or pregnancy morbidity. Now, how do you define each of these? Vascular thrombosis, how do you define it? It can be arterial or venous or small vessel. It can be 1 or greater than 1. Now, how do you define pregnancy morbidity? Again, there are 3 types of pregnancy morbidity: greater than or equal to 1 fetal death at or beyond the 10th week of gestation. Now, this was put up because before the 10th week of gestation, most of the fetal deaths are because of your congenital abnormalities. So, greater than or equal to 1 fetal death beyond the 10th week of gestation, greater than or equal to 1 premature birth before the 34th week of gestation because of eclampsia, severe preeclampsia or placental insufficiency, or greater than or equal to 3 consecutive embryonic losses before the 10th week of gestation, after all karyotypic abnormalities have been ruled out. Now, this is also a prerequisite. You need to rule out all karyotypic and congenital abnormalities before testing for APS in the third scenario. Okay, so pregnancy morbidity, please try to remember this: a fetal death beyond 10th week, or a premature birth due to preeclampsia, eclampsia or placental insufficiency, or greater than or equal to 3 fetal losses before the 10th week of gestation after ruling out congenital abnormalities. So these are the clinical criteria, and you need at least one of these. Laboratory criteria. So what is laboratory criteria? Broadly defining, laboratory criteria means persistently positive antiphospholipid antibodies. Now, what are the antiphospholipid antibodies you can test? So as we go through the discussion, you will know that there are a lot of these antibodies, and the consensus was developed so that they can decide which antibodies to test, and they finally came to the conclusion that these 3 antibodies are very specific for the diagnosis of antiphospholipid syndrome. Now, what are these antibodies? The Lupus Anticoagulant, the Anticardiolypin Antibody, and the anti-beta 2 glycoprotein 1 antibody. Now, these have to be positive on two occasions because sometimes you get transient positivity, therefore, you need to confirm that they are persistent. Now, how do you confirm that they are persistent? By testing them at two time points 12 weeks apart. You test the patient today, she or he is positive, repeat the test after 12 weeks. If they still are positive, then you call them to be persistently positive, and the titer is also given, which we shall discuss shortly. So, definite APS is present if at least one of the clinical criteria and one of the laboratory criteria are present. So, even among these three antibodies, any one antibody, if it is persistently positive, your laboratory criteria is satisfied. Now, we shall see this in detail. So, how do you classify the disease as such? APS or antiphospholipid antibody syndrome can be classified clinically into these four categories: primary APS, secondary APS, seronegative APS, and catastrophic APS, also known as PAPS, SAPS, SNAPS, and CAPS. Okay, so what is primary APS? Anything primary means that they are not associated with a secondary cause. So that is what is primary. APS being an autoimmune condition usually comes in association with other autoimmune diseases, most commonly your SLE, rheumatoid arthritis, etc. But if it is not associated with any autoimmune disorder, you call it as primary APS. If it is associated with a secondary cause, you call it as secondary APS. If it is negative for all the antibodies, which can happen, you call it as seronegative APS. And this graph is wrong. If the clinical features are present, no, it's right, sorry. If the clinical features are present, but the lab criteria are not present, you call it as SNAPS, that is seronegative APS. If the lab criteria are present, but the clinical features are not present, some propose the term pre-APS, but usually in the present scenario, we consider them as false positives or transient antibodies, and therefore we advise repeat testing. So only when there is both the clinical and the laboratory criteria, you call it as antiphospholipid syndrome. So this is how you classify the antiphospholipid syndrome. This is mainly clinical with regards to how you diagnose and label the patient. So, what is the difference between primary and secondary APS? We had already discussed. Now, this table shows you the different secondary causes for secondary APS. Usually, they are autoimmune disorders like SLE, rheumatoid arthritis, systemic sclerosis. It can also be a drug-induced autoimmunity. Can be associated with malignancies like leukemias, lymphomas, solid tumors, and myeloproliferative neoplasms like essential thrombocytosis. It can be associated with infections, which can be viral, bacterial, fungal, or protozoal. It can be associated with neurological disorders, liver disease, valvular heart disease, peripheral arterial disease, chronic renal failure, sickle cell disease, and EDTA dependent pseudothrombocytopenia. Now, I'm not going into the details of these secondary causes because it's actually not yet proven why this association actually happens. Though in autoimmunity, it can be explained logically because APS is also a autoimmune condition. It is still not known why APS is seen in association with the other secondary causes. Okay, so moving into the secondary APS, secondary to the autoimmune diseases, it's important to know that at least 30% of patients with SLE will develop APS. So that is why there is one school of thought that even if patients with SLE do not have thrombosis or pregnancy morbidity, they should be tested for APS. So previously I told you test for APS only if they have the clinical criteria, but in present day scenario, even patients with SLE are tested for APS. That is because 30% of these patients will develop APS, and 37% of APS patients have SLE. That is 37% of APS patients have SLE and a secondary APS. So in these patients, The predictors of thrombosis. Now, let's say we have a patient with SLD. How can you say that these patients will develop thrombosis? If these patients have a high titer of anticardiolypin antibody, if they have positivity for anti-beta 2 glycoprotein 1, and if the type of antibody is IgG, it can be either IgG or IgM. Okay, if it is IgG, they have a higher propensity for thrombosis, and if they have additional thrombophilia risk factors, again they can develop thrombosis. Similarly, in rheumatoid arthritis, there can be up to 28% of patients who can develop APS. Okay, so this is about secondary APS. Now, moving on to the pathogenesis of APS. So, as we already saw, the main problem in APS is thrombosis and pregnancy morbidity. How does APS cause this? Okay, so these antiphospholipid antibodies, they increase the expression of tissue factor on the vascular endothelium. Now, how does tissue factor appear on the vascular endothelium? Whenever there is endothelial injury. So, it is postulated that these antiphospholipid antibodies injure the endothelial vessel wall and thereby increase the expression of tissue factor. Now, once tissue factor is expressed, the coagulation pathway is triggered and there is a fibrin clot formed in the end, and that contributes to thrombosis. Also, these antiphospholipid antibodies activate the platelets and the monocytes. Now, these platelets, once they get activated, as we all know, they become thrombogenic and they form thrombi. Also, the antiphospholipid antibodies inhibit the endogenous anticoagulant and fibrinolytic mechanisms, and they also activate the complement. Now, this complement activation is supposed to be one pathway by which the vascular endothelium is injured. Okay, so if we go into depth, this is going to be very confusing because there are a lot of pathways involved. So, I want you to broadly remember that antiphospholipid antibody, they injure the vascular endothelium, they activate the platelets and monocytes, they inhibit the endogenous anticoagulant and fibrinolytic pathways, and they activate complement. This is how they cause thrombosis. Okay, so in a patient with APS, when these factors are all present, they are already in a highly thrombogenic state or a hypercoagulable state. Now, when there is a second hit like smoking or infection or trauma, surgery, drugs, etc., these patients present with thrombosis. Now, this theory is known as the two-hit theory, where there is already a pre-existing hypercoagulable state due to the antiphospholipid antibodies, and there is a second hit happening leading to imminent thrombosis. Okay, so this is about thrombotic APS. Now, there is something called obstetric APS, nothing but the APS which causes pregnancy morbidity. Now, why should we discuss this separately? Because it's proposed that this kind of APS has a completely different pathogenesis. The pathogenesis is that it directly binds to the trophoblast and it stops or inhibits trophoblast proliferation and differentiation. This does not happen on any other cell in APS. This happens particularly on the trophoblast, and therefore there is trophoblast apoptosis, and once there is trophoblast apoptosis, the vascularization of the placenta is affected, and therefore the fetal blood flow is affected. There is placental insufficiency resulting in fetal demise or fetal growth restriction or preeclampsia, eclampsia, etc. Okay, it also has anti-angiogenic effects. It can also bind to the decidual cells and the extravillous trophoblast and cause an inflammatory milieu, and it also activates the complement system, as we already know, and this complement has a counter connection with the coagulation pathway. So, activation of complement indirectly activates the coagulation pathway and results in fibrin clot formation. So, there are small fibrin thrombi within the placental vessels causing placental insufficiency. So, that is why if you see whenever there is a placental microthrombi, it is suggested to look for hypercoagulable states in the mother, particularly lupus antiphospholipid syndrome. So this is the pathogenesis of obstetric APS, and this is the reason why among all other clinical presentations of APS, pregnancy morbidity is the most common. Okay, so now we have seen the pathogenesis of APS as to how it causes thrombosis and pregnancy morbidity. Next, we come to the types of antibodies. Now, these antibodies can be divided into two types as far as APS is concerned, as criteria antiphospholipid antibodies and non-criteria antiphospholipid antibodies. So, as the name suggests, anything which comes in the Apporo criteria is known as the criteria antiphospholipid antibody, and the others are called as non-criteria antiphospholipid antibody. So why was it decided like this? Because they found out that these three antibodies were more specific for the diagnosis of antiphospholipid syndrome. So what are they? The anticardiolepin antibody, the anti-beta to glycoprotein 1 antibody, and the lupus anticoagulant. Okay. Now lupus anticoagulant, we do not see what kind of antibody it is because it is tested with a coagulation based testing, whereas anticardiolipin antibody and anti-beta to glycoprotein 1, we do it through ELISA. So you actually find out what kind of antibody it is, whether it is IgG or IgM. Okay, so it can be either IgG or IgM positivity. Okay, so the other antiphospholipid antibody syndrome, which can be positive in these patients, however, even if you identify them according to the criteria, you cannot diagnose them as antiphospholipid syndrome. Now they are anticardiolipin antibody IgA type, anti-beta to glycoprotein 1 antibody IgA type, anti-annexin A2. Now you need to remember that all these proteins, this cardiolipin, beta to glycoprotein, annexin, vimentin, annexin A5, phosphatidylethanolamine, inositol, prothrombin, phosphatidylserine, all these are actually the plasma proteins which are binding to the phospholipids. So there are antibodies against these phospholipid components or plasma proteins bound to the phospholipids which are found in APS. But what we test for commonly are these three. Okay, so you need to remember that the patients may actually present clinically with many of the symptoms of APS and they might be negative for these antibodies. Why? Because those patients might be having these antibodies, and that is why the diagnosis of APS is actually tricky, because the patients may actually be presenting with the symptoms of APS, but because we don't test for these antibodies, we might be actually missing them, and that is where the category of SNAPS comes in, seronegative antiphospholipid syndrome. Okay. Common labs provide these three antibodies. However, there are certain research labs and high-end labs which still provide these non-criteria antiphospholipid antibodies. Okay, so now going specifically into the criteria antiphospholipid antibodies, the first one will be lupus anticoagulant. As a pathologist, as a hematopathologist, this will be the antibody which you will be requested to test for, because the anticardiolipin and the anti-beta to glycoprotein antibodies are tested in a biochemical lab by the use of ELISA. So we'll be reading about this in detail. So lupus anticoagulant. Now, how this name came about? Lupus name came about because it was associated very common with systemic lupus erythematosus, and anticoagulant because it has an ability to prolong phospholipid based clotting tests. Now this picture, this is your normal coagulation pathway. There is an intrinsic pathway, there is an extrinsic pathway, and there is a common pathway. Now you need to understand that there are few steps in the coagulation pathway which are dependent on the phospholipids. So as you can see here, there is a factor 10 to 10A conversion which requires phospholipid, factor 2 to 2A, that is prothrombin to thrombin, which again requires a phospholipid, and also the activation of factor 7 to 7A also requires a phospholipid. So there are three phospholipid dependent steps in the coagulation pathway, and because this antibody interferes with this phospholipid function, okay, the antibody is not directed to this phospholipid, it is directed to some plasma protein which binds to this phospholipid. It's believed to be either prothrombin or anti-beta to glycoprotein protein. Now here again the knowledge is deficient. Nobody knows which plasma protein it is directed against. However, it interferes with the function of this phospholipid and thereby prolongs the clotting time. Now let's say it interferes with this phospholipid, it is going to prolong the APTT, and if it interferes with this phospholipid, it is going to interfere with the PT. So depending upon which phospholipid it interferes with, that clotting time will be prolonged, and usually it is the APTT which is prolonged in lupus anticoagulant. Usually, meaning almost 99.9% of the time, it is the APTT which is prolonged. But at the same time, I want you to remember that it doesn't mean PT cannot be prolonged in lupus anticoagulant positive patients. PT can also be prolonged because we know that it is actually a phospholipid interfering antibody. So if the phospholipid involved in your extrinsic pathway is inhibited, your PT will be prolonged. So depending upon the degree of inhibition of the phospholipid, any time can be prolonged. So this is how lupus anticoagulant got its name. So next, moving on to anticardiolypin antibody. Now, this is how we got the false positivity in the VDRL test. So in the VDRL test, there is a cardiolipin antigen which is embedded on the ELISA plate, and antibody against this cardiolipin reagent is what caused the false positivity in those patients with SLE. Okay, so this antibody is known as the anticardiolipin antibody, and anti-beta to glycoprotein 1 antibody is interesting. There is a little in-depth analysis required here. So it is actually a circular protein. It's a circulating plasma protein. So beta 2 glycoprotein is a circulating plasma protein, and it is present in a circular configuration when it's in the circulation, and it has 5 domains named as D1, D2, D3, D4 and D5. Okay, now this D1 domain has an epitope known as R39 to R43. In the circular configuration, this domain is actually hidden. Okay, but once it comes closer to the phospholipid during coagulation or during some other process, when this beta 2 glycoprotein comes close to the phospholipid, it unfolds itself and becomes an S form. Okay, and once the D5 domain binds to the phospholipid, it becomes a J form. And once this J conformation is attained, this epitope is actually available for the antibody to bind. Now, this anti-beta 2 glycoprotein is important because this is how we actually understood how the antiphospholipid antibody works, especially when the binding to phospholipid happens. Okay, so that is why this antibody is known as 1. So it is directed against the domain 1 of the beta 2 glycoprotein molecule. That is why it is known as the anti-beta 2 glycoprotein 1 antibody. Okay, so next, moving on to the epidemiology of the disease. It can be seen in normal individuals as well, and not the epidemiology of the disease, the epidemiology of the antibodies. So antiphospholipid antibodies can also be seen in normal individuals, but they are usually transient, and it's present in 1 to 5% of the healthy population. In fact, it's more common in the elderly population. And as age increases, the possibility of pathogenic antibody increases. What I meant is, if a pediatric patient shows antiphospholipid antibodies, they are likely to be transient, whereas as age increases, positivity for an antiphospholipid antibody means that they are likely to develop an APS. Okay, they can also be seen transiently with infections such as HCV, HIV, CMV, EBV, adenovirus, parvovirus, etc. They can be seen with syphilis and leprosy. They can be seen in association with intake of drugs such as procainamide, phenothiazine, quinine, OCP, anti-TNF agents. Can be seen in association with malignancies, and they are not pathogenic because they do not have an associated thrombotic risk. Now, coming to how commonly these antiphospholipid antibodies cause thrombosis. They can cause both arterial and venous thrombosis. Venous thrombosis is more common compared to arterial thrombosis. Now, even in that arterial thrombosis, anticardiolipin antibody is associated with arterial thrombosis than any of them. And when venous thrombosis is considered, both anticardiolipin antibody and lupus anticoagulant both are associated with increased risk of thrombosis. In pediatrics, patients with lupus anticoagulant and anticardiolipin antibody have more of a pregnancy morbidity, and many other studies have suggested that a strong positivity for lupus anticoagulant is a very good pointer of risk for recurrent abortions. Whereas if you see patients with preeclampsia and eclampsia, they were found to have strong positivity for anti-beta 2 glycoprotein 1. These are different studies quoted, and they might not be important from a student point of view. However, these are good to know things. So next, coming to the diagnosis. So we already saw how the diagnosis is done. It's done based on both clinical and laboratory criteria. Now, clinical, we already saw it can be either thrombosis related or pregnancy related morbidity, which we have already discussed in detail. And thrombosis again can be arterial or venous or small vessel thrombosis, just requires imaging. And laboratory criteria, any one of these three, that is lupus anticoagulant, anticardiolipin antibody, anti beta 2 glycoprotein 1 antibody. Now, lupus anticoagulant, when do you call it positive? It has to be done according to the ISTH guidelines. We shall see that in detail. When do you call anticardiolipin or anti beta 2 glycoprotein 1 antibody positive? The unit is greater than 40. Okay, greater than 40 GPL or MPL. Now, G means IgG phospholipid, GPL. MPL is for IgM phospholipid. Okay, so if it is greater than 40 or if it is greater than 99th percentile. Now, this is what you calculate in your lab. You take a cohort of normal population, you see their titer of anticardiolipin antibody, and then you calculate the percentile, and anything greater than the 99th percentile, those patients are said to be positive. This applies for both anticardiolipin antibody and anti-beta 2 glycoprotein 1 antibody. Okay, so first we will look into the clinical criteria. We have already discussed how you look for thrombosis. It can be arterial or venous. You have to just confirm it by imaging. So as I already said, it can be there at any site, and venous thrombosis is more common than arterial. It's usually deep vein thrombosis in the deep veins of the leg. The next common site of thrombosis is pulmonary thromboembolism, followed by cerebrovascular thrombosis. Arterial thrombosis is much less common. It's seen only in 1/3 of the cases. But the point to be noted is that the mortality is higher with arterial thrombosis. And in arterial, cerebral is the most common, and these patients present with TIA and stroke. The next common sites are coronary, presenting with MI, and leg ulcers, where there is a peripheral arterial disease and causing extremity vascular insufficiency. And pregnancy morbidity we have already discussed in detail. Now, is this all? No. Just like your non-criteria antiphospholipid antibodies, there are also non-criteria clinical manifestations. So they are known as non-criteria clinical manifestations. These can be seen in every organ system of the body, though they do not contribute to labeling a patient as APS. They can actually be a pointer to the diagnosis. Okay, so your famous Liebman-Sachs endocarditis, which is large sterile vegetations within the heart, which are actually fibrin thrombi. They are also seen in your APS. Dermatologically, you can see livedo reticularis. Hematologically, you can see autoimmune cytopenias like autoimmune hemolytic anemia. You can see Raynaud's phenomena. You can see amyloraxis fugax, which is actually the transient blurring of the vision due to thrombi in the retinal vessels. You can also have renal manifestations like thrombotic microangiopathy. So when you have thrombotic microangiopathy in combination with APS, it is known as the APS nephropathy. So all these non-criteria manifestations can also be seen in these patients. Then there is something known as catastrophic APS. So when we were discussing the classification, the fourth type of APS was the catastrophic APS. Now this again has a criteria, and we shall discuss the importance of this diagnosis. So the criteria is that at least 3 or more organ systems should be involved, and the manifestations should develop simultaneously or less than a week, and that is why it is known as catastrophic. The patients are usually sick and they present in an emergency with multi-site thrombosis. That is, they develop it within a week or at the same time, and you need to confirm with histopathology that there is a small vessel thrombosis in at least one organ, and also you need a laboratory confirmation for the presence of antiphospholipid syndromes. Now you call it definite catastrophic APS when all the 4 criteria are present, and you call it probable catastrophic APS when there are certain misfits within this criteria. I'm not going into detail. Whenever you have a case of catastrophic APS, you can go into detail into these criteria and see if your case fits into this. So what you need to remember is there is something known as catastrophic APS, shortly known as CAPS. So that was about catastrophic APS. Now we move on to maybe the most important part of this disease, that is the laboratory diagnosis of APS, in particular lupus anticoagulant, because as I already told you, anticardiolypin and anti-beta 2 glycoprotein antibody are ELISA based tests that are done in a biochemistry lab. So what we will be dealing with is the lupus anticoagulant, which is actually detected by a coagulation based testing. Why? Because we are making use of the ability of this antibody to prolong phospholipid based clotting test, and it's believed that this antibody is actually directed against the beta 2 glycoprotein and prothrombin, but we are not sure about it yet. Okay. Yes. Now we go on to the lupus anticoagulant testing. So there are different um, assays used. Now, how do you call them different? They are different based on the principle on which these tests happen. Okay, for example, now this DRVVT stands for dilute Russell Viper venom test, and lupus sensitive PTT means lupus sensitive partial thromboplastin time. SCT means silica clotting time. KCT means kaolin clotting time. Now, DRVVT is based on the principle that it directly activates factor 10. So it activates factor 10 to 10A. So it actually tests only this pathway. And we know that 10 to 10A has phospholipid involved, and 2 to 2A again has phospholipid involved. So it actually tests 2 phospholipid based assays. And now if you see the other tests like your lupus sensitive LA, which is lupus sensitive PTT, which is known as Taclot LA, SCT, KCT, they test the entire intrinsic pathway. Okay, because they contain the contact activator, they contain the phospholipid, and they test the entire intrinsic pathway. Now, what is the advantage of a DRVVT compared to a lupus sensitive PTT or an SCT or KCT? Now, let's say the patient has an inhibitor against factor 11. So, any inhibitor against factor 11 will also prolong the APTT. So, we are not actually sure whether the prolonged clotting time is because of an inhibitor against factor 11 or an inhibitor against the phospholipid, which is the lupus anticoagulant. In that way, your DRVVT actually excludes the upper part of the pathway and it tests only this part of the pathway. Okay, so it starts from factor 10 until fibrin formation, thereby helping us to identify if the prolonged clotting time is due to a lupus anticoagulant or due to some factor inhibitor. Okay, so that is one advantage of the dilute Russell Viper venom test. Now, everyone dreads testing for a lupus anticoagulant because there are a lot of guidelines and criteria proposed for the same, and this also was decided in the Sydney conference in 2006, which is being revised every year. The latest revision, I believe, was in the year 2019 or 20, and it is still going to be revised as newer techniques evolve. Okay, so what is the basic criteria? I hope you can remember this slide because this is very important in your practice. So, whenever you're going to test for LA, you will have to select two tests based on different principles. Now, these are the different tests available, and you need to select two tests based on different principles. So, one test from this mixture, maybe, which actually assists the intrinsic pathway, and one test from this principle where it actually starts activates the factor 10. So you can use a DRVVT and a lupus sensitive PTT. That is what Sydney criteria says. Okay, so there you should use two tests based on different principles. DRBVT should be the first test considered, and the second test should be a sensitive APTT. And this APTT should contain low phospholipids and silicase activator. Now, this part I shall explain in detail later. And when do you call lupus anticoagulant is positive? You can call lupus anticoagulant is positive if any one of the two tests is positive. So this means that if you need to say that a patient is lupus anticoagulant negative, you should do at least two tests and prove that they are negative. However, even if one test is positive, the patient is positive for lupus anticoagulant. So this is what the ISTH criteria says, and understanding this is important in reporting lupus anticoagulant reports. Okay, so now I ordered two tests for my lab. I ordered a DRVVT and I ordered a lupus sensitive APTT. Now the ISTH tells me, it starts confusing me further, saying that with each test you need to do three steps. That is screen, mix and confirm. Okay, now what is this? Okay, now let me take the first kit. I am taking the DRVV kit. Okay, and the DRVVT kit has a screen reagent and a confirm reagent. Now, what am I supposed to do with this? Okay, so what I will do is I'll take the patient's sample and I will add the screen reagent and I will measure the clotting time. Now, what do you mean by screen reagent? So actually, for any clotting reaction to take place, you know that we need calcium chloride and we need a phospholipid. Okay, so this is the basic principle. We need calcium chloride and we need phospholipid. Of course, first phospholipid and then the calcium chloride. So, in a patient with lupus anticoagulant, this phospholipid's function is going to be interfered with. I think I have a better picture. Yeah. So we'll go here. So in a normal patient, so the factor 10 is to be converted by 10A on the addition of the dilute Russell Viper venom, which is present in the screen reagent. Okay. And this screen reagent also has a little bit of phospholipid. Within the body, the phospholipid is actually provided by the platelet, whereas in vitro, when you're testing, you actually remove the platelets and you artificially add phospholipid in the form of the reagent. Okay, so if this reagent contains very minimal amount of phospholipid, then the lupus anticoagulant present in the patient sample will bind to this phospholipid and therefore the clotting time will be prolonged. Whereas in a normal patient there is no antibody, therefore even the minimal amount of phospholipid is sufficient for the reaction to take place. So this reagent, which contains very minimal amount of phospholipid, is known as the screening reagent. Okay, so that is what happens in the screen step. In the screen step, you use a reagent with minimal amount of phospholipid so that if the patient has a lupus anticoagulant, that phospholipid is inhibited and the clotting time is prolonged. So if there is a prolonged clotting time in the screening test, that means the patient may have a lupus anticoagulant. And then you go to the next step, which is the mixing step. In the mixing step, this is just similar to the mixing study you do for factor deficiencies. Here you mix 50-50. That is 50% of patient's plasma and 50% of pooled normal plasma. If it is due to deficiency of the factor, your clotting time will be corrected. And if it is due to an antibody present in the patient, then the prolonged clotting time will not be corrected. Now let's say we are doing the DRVV. We did the screening with the screening reagent which contained minimal amount of phospholipid. The patient has lupus anticoagulant, so the clotting time got prolonged. Now you take the same patient's sample. The patient has a lupus anticoagulant which is shown by these antibodies, and then you add the normal plasma. Once you add the normal plasma, the factors within the normal plasma are also inhibited by this antibody, and therefore the clotting time is not prolonged. So again, in the mixing study, there will still be a prolongation of the clotting time if the patient has a lupus anticoagulant. Then you follow it with a confirming study. Now, what is the confirming study? You confirm that the antibody is lupus anticoagulant only. How do you confirm that? You confirm that with the knowledge that the lupus anticoagulant is actually directed against the phospholipid. So what do? In the confirm reagent, there is excess of phospholipids. So this is the confirm step. It has excess of phospholipids, much more amount of phospholipid than is normally required. And if you repeat the assay now with the patient sample, what happens? The patient has a lupus anticoagulant which will inhibit a little bit of phospholipids, but there is excess of phospholipids, and therefore the reaction can continue normally, and the clotting time which was prolonged in the screening step and the mixing step gets corrected in the confirm step. Now, this demonstrates the dependence of the antibody on phospholipids, because you didn't change anything, you just added a little bit of excess phospholipids, and that corrected the defect in the clotting time. So that demonstrates the dependence of the antibodies on the phospholipid, confirming that this is a lupus anticoagulant. Now, this is the principle of testing for lupus anticoagulant. Now, I did screen, mix, and confirm, and in every step, it showed me that the patient is actually having a lupus anticoagulant only. So once all these three steps are done, I can now say that the patient is positive for lupus anticoagulant by the dilute Russell Viper venom test. Now let's say the patient was negative. Negative in any step for that matter, maybe during the mixing step or during the confirm step, the patient becomes negative. Then you do another test, that is the lupus sensitive APTT. The lupus sensitive APTT also has two reagents, the screen reagent and the confirm reagent. With the screen reagent, let's say he has a prolonged clotting time, mix, the time is still prolonged, confirm, the time gets corrected. Now the patient is again positive for lupus anticoagulant, but this time it is by the lupus sensitive APTT method. So you at least need to do two tests before calling it negative. But even if one test is positive, you can call them positive. Okay. So that is the principle of the confirmatory study, which demonstrates the phospholipid dependence of the inhibitor. So in the screen reagent, you have decreased amount of phospholipid, therefore the clotting time is prolonged. Whereas in the confirmed reagent, you have an increased amount of phospholipids, therefore the clotting time becomes shortened. Okay, so this is actually the flow chart, how you test a patient for lupus anticoagulant. I'm sorry, this DRVV is supposed to be the first test to be done, followed by the PTTLA. So now let's say the DRVV screen is positive, you follow it by the mix. If there is no correction, again it means it is positive, then you follow it up with confirm. If it is again positive, you say positive for lupus anticoagulant by DRVVT. Now, if it is negative, then you move on to the test using another principle, that is the lupus sensitive PTT, also known as the PTT-LA. Now, That again, if the screen is positive, follow it up with mix. If again that is positive, you confirm it, follow it up with the confirm step. That again is positive, you report it as positive for LA by PTTLA. If in any of these steps it is negative, the patient is negative for lupus anticoagulant, but however, the patient can have several other conditions like factor inhibitor or factor deficiency, which actually cause the screening time to be prolonged. Okay, so that comes in a separate discussion of assessing a patient with bleeding disorders or abnormalities of PTA, PTT. So let's restrict our discussion to lupus anticoagulant. This is how you test for lupus anticoagulant. Okay, now what? You got a positivity for lupus anticoagulant by one test. Now let's say DRVVT. Before labeling the patient as APS, you need to repeat this test after 12 weeks. So that now let's say the DRVVT was positive, you will repeat the same DRVVT after 12 weeks and confirm that it is still positive. That is when you can label the patient as APS. Okay. Now, again, there are important pitfalls in testing for lupus anticoagulant. You have to avoid testing in the acute phase. Now, there are several reasons for this. There can be false positives as well as false negatives. Now, let's say the patient recently had an abortion or recently had a thrombosis. This event consumes all the antibodies, and the patient may transiently be lacking the antibodies. So there can be a false negative during this phase. Or let's say there was an acute inflammation during which there was an increase in the CRP, the C reactive protein in the patient. This CRP can cause a false positive lupus anticoagulant. So that is why in the acute phase both false positive and false negative results are possible. So you need to avoid testing for lupus anticoagulant in the acute phase. And of course you have to avoid testing while on anticoagulants. Why? Because lupus anticoagulant is based on coagulation testing. So any anticoagulant will prolong the clotting time. So if you're going to do the lupus testing while the patient is on anticoagulant, that will give you a false positive report. So you cannot test for lupus anticoagulant while the patient is on, let's say, warfarin or heparin or newer anticoagulants, anything for that matter. Okay, so when does the acute phase end? When do you test if you actually want to test after an event of thrombosis? In an ideal setting, you need to wait for 6 months. However, nobody can wait for 6 months. So the ISTH says you wait at least for 3 months after an acute thrombotic event. If the patient is on anticoagulants, at least 2 weeks after stopping heparin. If the patient is on warfarin, when the PTINR comes to less than 1.5, you can test them for lupus anticoagulants. And if the patient has had a recent abortion and you need to test it immediately, wait at least for 6 weeks, if not for 3 months. Okay, so these are the guidelines as to when you test for lupus anticoagulant after an acute event. So this is really important because most of the patients have their tests done in the early phase after the event, and therefore are falsely labeled as APS and treated for the same, which is not right. So this is just a slide which I included for completion's sake about doing an ELISA testing for anti-beta 2 glycoprotein and anticardiolipin. It's just like any other normal ELISA where you have a coated well. The well is coated with the cardiolipin and then you add the patient's sera and the antibody binds in, and then you add a secondary antibody with an enzyme conjugate, and then you add a substrate for the enzyme, and based upon the intensity of the color which is formed, you can measure the titer of the antibody. So that was about testing for lupus anticoagulant and anti-beta 2 glycoprotein antibody and anticardiolipin antibody. Non-criteria phospholipids, for one thing, I'm not sure how they are tested, and second point is even if you test for them, they are unlikely to be useful for treatment decision making. Okay, so coming to the treatment, why is diagnosis of APS important? So from this discussion, I hope you would have understood that it's a highly thrombophilic condition. So you need to give anticoagulation for these patients. And the patients are actually classified into different risk groups based on what antibodies they are positive for. They can be high risk, medium risk, or low risk. This OR refers to the odds ratio of greater than 9. So this group of patients have an odds ratio of greater than 9, meaning they have 9 times increased risk than healthy controls to develop thrombosis. So these high risk patients, who are they? Triple positive, meaning they are positive for lupus anticoagulant, anti-beta to glycoprotein antibody, and anticardiolipin antibody. So they have the highest risk, and if these patients have any kind of thrombosis, then you have to give them extended anticoagulation, meaning long-term anticoagulation, and the anticoagulant of choice is warfarin. Till today, newer anticoagulants are not proposed for APS. The best anticoagulant of choice for APS is warfarin or vitamin K antagonist, and these patients have to take warfarin for extended periods of time, and they have to maintain a PT-INR of 2 to 3. Here there is one place where it shows as INR 3 to 4. This was in the older guidelines, but right now the guideline for PT-INR on warfarin is 2 to 3, even in antiphospholipid syndrome. And if there is arterial thrombosis, we also add aspirin along with warfarin. If the patient is pregnant, since warfarin is contraindicated during pregnancy, we use unfractionated heparin in these patients. So, how do you define medium risk patients? Any kind of double positivity or single positivity for lupus anticoagulant. So we discussed earlier that lupus anticoagulant has the highest risk of thrombosis. So if the patient has only one antibody positive, but that antibody is lupus anticoagulant, they come under medium risk, and they again require vitamin K antagonist therapy. And again, in low risk, again you need vitamin K antagonist therapy, but you take this on a case to case basis. Now let's say the patient also has some other added high risk factors, then you give them plus or minus aspirin. Okay, so the take home message from this slide is APS patients have to be anticoagulated for extended periods of time. The anticoagulant of choice is warfarin, and a PT-INR of 2 to 3 has to be maintained. And based upon the risk of the case and the site of thrombosis, you may or may not add aspirin. Slide on the treatment of CAPS. Now, CAPS or catastrophic APS is a medical emergency. It's something like DIC, where the patient presents with widespread thrombosis and organ dysfunction. These patients may be treated with IVIG or plasmapheresis to remove the antibodies. Rituximab, which is an anti-CD20 monoclonal antibody, which destroys these B cells, which differentiate into plasma cells and produce these antibodies. So rituximab can also be used, and steroids are the last stay of resort. Usually in APS, secondary APS associated with autoimmune diseases, steroids are added to control the autoimmune condition. So treating that autoimmune condition also suppresses the APS in those scenarios. Whereas in CAPS, steroids usually have a very limited role, and we need to treat them much more aggressively with IVIG, plasmapheresis, and rituximab. Okay, so I think point on how you monitor anticoagulant therapy, because this is a very disregarded part in coagulation, PT-INR. Labs do not recognize the importance of this test. So, how do you monitor a patient on warfarin? You advise them to do PT-INR. Now, just a point on why you need to do INR. Why is a PT not enough? Okay, so INR stands for International Normalized Ratio, which is actually a ratio of the PT of the patient upon the geometric mean normal PT raised to the ISI. ISI stands for International Sensitivity Index. Now, this table, I would like to draw your attention to this table, which exactly explains why you need to use an INR. Now, there are different reagents. Now, a lab in Noida is using reagent A, a lab in Kerala is using reagent B, a lab in Hyderabad, a lab in Malaysia, a lab in US. Okay, so they are using completely different reagents and they get completely different PTs. But their ISIs are different. Now, this ISI is provided by the reagent person who provides the reagent kit provides the ISI, and the ISI is also different. So when you apply this ISI to this PT, you can see that the INR is the same across all the labs. Okay, so the main function of INR is to normalize the PT across the different areas by standardizing the PT reagent sensitivity. Okay, so this international sensitivity index is what? Now let's say the reagent company in Noida, they made a PT reagent. They standardize this PT reagent with the international standard which the WHO has created, and then they see the correction factor. Now, this correction factor is what is ISI, International Sensitivity Index. Now, how do you select a PT reagent? You need to select a PT reagent which has an ISI of close to 1. Now, what does an ISI close to 1 mean? It means that the PT reagent provided by your seller is very close to the international standard in its sensitivity to measure the correct PT. Now, this is what an ISI means. That is why whenever you're purchasing a PT reagent, you need to see that your ISI is as close to 1 as possible. Okay, so this is a responsibility of the buyer. The buyer actually standardizes his PT reagent to the international standard and calculates the ISI and gives that to you. And that is what you apply on the PT you calculate. Okay, so ISI is a measure of sensitivity of a particular thromboplastin reagent to warfarin induced reduction of vitamin K dependent clotting factors. And the international reference plasma has a ISI of 1. So if your PT reagent has an ISI of 1, it means that your PT reagent is very similar to the international reference plasma. That is how this ISI allows comparability of different PT INRs. And actually, a PT-INR is a value which is used only for patients on vitamin K antagonists, but somehow it is used for every patient in whom a PT is done. That is not actually necessary. PT-INR is because the doses are decided in different clinics based on the PT-INR. So they have to be standardized, and that is why the PT-INR was created for these patients. However, the routine preoperative measurement of prothrombin time, patients with bleeding disorders, they do not require PT-INR. I hope you got certain valuable points from this slide, and that is why I wanted to include this here. So this is my last slide. To summarize, Antiphospholipid syndrome is an autoimmune disorder where autoantibodies are produced against proteins bound to phospholipids. It can be primary or secondary. The diagnosis is based on both clinical and laboratory criteria, at least one clinical criteria along with one laboratory criteria, and this is known as the Sydney modification of Apporo Criteria. Clinical is vascular thrombosis or pregnancy morbidity, and laboratory criteria is Lupus Anticoagulant, which is tested with coagulation studies, or anti-beta 2 glycoprotein 1 and Anticardiolypin, which are ELISA-based tests. Lupus anticoagulant testing should not be done in the acute phase or while the patient is on anticoagulants. Testing should follow ISTH guidelines, and if positive, should be repeated after 12 weeks. And these patients require extended anticoagulation with vitamin K antagonist. Last but not the least, do not forget about CAPS, which is a medical emergency. Immediately as you think of DIC when a patient presents with bleeding and thrombosis simultaneously, also think of catastrophic APS. Thank you.
Wow. Thank you. Have a glass of water. Okay, Dr. Karthika, you are superb. Unbelievably good. Too good, rather. I mean, you're a fantastic teacher. What knowledge and the way you explain things. You really need a standing ovation for such a wonderful presentation. I will just read out a comment made by Dr. Nilesh Kapadia. He is a very famous pathologist from Ahmedabad, Gujarat. And what he writes on YouTube is, "We are lucky to have a great teacher like her. Pleased to hear."
Thank
So
you.
you can see what a great, great, great impact you are making. And there are, I mean, it is just a to, you just can't, you're running short of words to explain how beautifully you've explained each and every bit of it. And to top it out, the way you explain the PTINR, that's wonderful, thromboplastin, and how it equates to the ISI concept of one, which half people do not understand, and I really need to keep them, making them understand that there's a lot of difference between human thromboplastin, the porcine, the bovine, and all that has a lot of things. So beautiful, beautiful, wonderful. This is something which I think everybody should listen to this lecture and learn what antiphospholipid process is all about. Brilliant. We will be waiting, patiently for your next lecture, and I think that is on hemophilia. Is that right?
We have myeloproliferative neoplasms as well, sir. But yeah,
Oh.
yeah.
Whatever it is, we'll wait as long as we are asked to wait. No issues, because it's a delight to listen to you and to learn from you. Brilliantly done. Please share the PDF of this. We will upload it, and we are coming with another capsule, whereupon we are trying to integrate all the lectures, the PDF, and the people who have spoken those lectures. So, are you giving consent to share your email ID?
Sure, sir. No problem.
Yeah, because many people do have a lot of queries. So we'll be having a single unit, a Google Drive, Excel sheet, whereupon everything will be available on one go. So that with the topic, you can choose the PDF as well as the video as well as this person who's spoken. We all integrated in one. So I think by the 1st of January we'll be coming up with that. Brilliantly done, Dr. Karthik. Wonderful. God bless you. Beautiful. Very nice. What a teaching. Brilliant. So, right. Take care. Then good night. Bye bye.
Thank you, sir. Good night.